Good afternoon, everyone, and welcome to our discussion about the calendar year 2021 Home Health Proposed PPS Rule. Before we begin, I just want to go over a few items so you know how to participate in today's event. You're listening using your computer speaker system by default, but if you want to join over the phone, just select telephone in the audio pane in the GoToWebinar control panel, and the dial-in information will be displayed. The handout for today's webinar can be obtained by expanding the handouts pane in the control panel and then clicking the file to open or download. We will be taking questions during the webinar, and we've allotted some time at the end to answer as many as we can. However, we do have a very full session. Please go ahead and submit your questions throughout the session by typing to the questions pane in the control panel, and we will answer what we can at the end. Now I'd like to start off today's session by introducing you to Michael Greenlee, founder and CEO of HealthRev Partners. Michael?
Hey, thanks, Megan, and thank you to everybody joining the call today. And before I introduce today's speaker, I'd like to share with you just a little bit about HealthRev Partners. Now, I wrote a script for this, but I'm really not a script guy, so I just want to talk with you as the of the organization. You know, over the past several years, we've seen the growing need for a more modern approach, an innovative approach to how revenue cycle management is handled. And as a result, you know, we offer coding and billing services that ensure timely, accurate claim submissions, chart reviews, and data that helps you make decisions concerning your business. It's backed by exceptional customer service. We have some of the best customer service people you could ever meet. Reliable, and we're very transparent in everything that we do. In fact, we're so confident in the level of services and the results that we get that, you know, we offer a 60-day trial period with all of our agreements. You know, I've seen just a lot of agencies that have been overpromised and underserved in this marketplace, and as a consumer myself, it makes sense to me for people to get to experience the services before they find themselves stuck in an agreement. And, you know, it's just the right thing to do, and you know, we're all about doing what we say we're going to do. So if you'd like to hear more about, you know, who we are and what we can do, we'd love to have you let us know that at the end of the webinar, and I'd be honored to have a conversation with you and just get to know a little bit more about your agency, and worst case scenario, you know, be there for if you need any type of advice or anything like that. But now I'd like to introduce today's presenter, John Reisinger. He is the principal of Innovative Financial Solutions for Home Health. He's also a CPA that specializes exclusively in the home health industry. Working in home health since 1992, John has held various roles, including Medicare auditor, as well as the vice president of a large reimbursement multi-state home health organization. He established his consulting company back in 2008, and since then has been leading the charge back to bringing back financial fundamentals to home health. John also licensed the industry's first patient budgeting tool called the Home Health Care Resource Planner. It's a web-based app that can enhance your profit potential while enabling you to provide better top-line care. As a strong advocate for the home health industry and a nationally recognized speaker on a wide variety of topics, we've asked John to join us today to discuss the various updates included in this home health proposed rule and their projected impacts to your organization. He will also talk about another passion of his, how the rulemaking process works and what that can do and how that would impact our industry, both now and in the future. So with that, I'd like to turn it over to John.
Hello, everybody, and thank you for joining us today. I want to get right into the presentation because there's a lot that we have to cover here. One of the things you'll notice that's a little different about my style of presentation is, as opposed to just giving you bullet points and you have to take all the notes, the detail is in the presentation itself so that you can look at this presentation tomorrow, a week from now, a month from now, 6 months from now, and you're going to be able to go through it and understand what I was talking about any specific points that you have questioned at that time. Okay, so again, we're talking about the 2021 Home Health Proposed Rule. So The home health PPS proposed rule is an annual occurrence, meaning that it's changed every year. And changes can vary year to year. Some year there's big changes, some year there's few changes, like this year. This year is a year with few changes. Okay, and sometimes the changes can be punitive. Those of you that have been around for a while know what I'm talking about. This is year 2 under PDGM, and that's why there's not as many changes as what there usually is. But there are some big changes. But I want to talk about just about any time CMS proposes a new rule or a change to an existing rule, we, the industry, have an opportunity to address those proposals via participating in the rulemaking process. And we do that by submitting comments to the various issues brought up in that proposed rule. Any and all interested parties can submit comments. I've even seen Medicare beneficiaries submit comments to proposed rules in the past. This, unfortunately, is not a commonly known right that we have in the industry. And history has shown that we can impact the proposal from CMS, but rarely do we impact it to the level that we wish because of far too few comments submitted and or too much copying and pasting of comments that are submitted. I mean, there have been some groups that have really tried to push the number of comments being submitted, and they've been pushing copying and pasting. And I think that's work that backfires against us. I think not only do they discount the increased volume, but it also detracts away from the original comment that everybody's copying and pasting. Industry participation really needs to increase. From 2008 through 2017, there were an average of 185 comments per year. Not a very impressive number, especially when there were approximately 12 to 13,000 agencies for most of that time, let alone all the consultants, vendors, EMRs, attorneys, etc., that work in the industry. If they work in the industry and they say they advocate for the industry, you might ask them, do they ever submit comments? And if they say yes, ask them what comments. Now, when you comment, you can pick anything that you want to comment on in the proposed rule. You can pick on one comment, or you can pick on you can pick a handful of comments. So for 2021, this year, that could include commenting on the following issues: telehealth, remote patient monitoring, the changes to the service areas of over 100 counties, a home health specific wage index, the outlier provision, and anything else that's identified in the 2021 proposed rule. And we'll touch on each of the above during this presentation. In commenting, CMS wants us to refer to file code CMS 1730-P. Okay, that becomes the code that lets them know what specific proposed rule your comment is in reference to. And comments can be submitted by regular mail. You can send them by express or overnight carriers. It's just all those need to be to CMS by 5 p.m. on Monday, August 24th. This Monday coming up. You can also send them in electronically at this website, but there you have until 11:59 p.m. Eastern Time on Monday the 24th. And here you can type your comments directly, or you can drag and drop a Word or PDF document here. As far as I'm concerned, electronically is the best, it's the easiest. And you can also submit your comments anonymously if you have any concerns. You don't want it to be associated with your agency. Most of the time, the comments that there's not enough anxiety with those comments, but you always have that option. Now, dates to be assured consideration by CMS. Again, the comments that are mailed have to be sent in by 5 p.m. They have to receive them by 5 p.m. on August 24th. And these are the addresses that you would send them to. And now if you go the electronic route, which is what I would recommend, this is what you're going to see when you start out. You've gone to that website, the address, the URL that I previously identified. You typed in CMS-1730-P, and this is what you see. And you see it's identifying the 2021 home health PPS rate update, etc. Okay, so here you want to put in your comments. You would click on the blue Comment Now button, and you'd be taken to the following page. And again, this is the easiest way to do it. Okay, so you can type your comments directly here. You see this page when you go there, and you see comment over in that page that I copied. You just start typing right there, and you can put up to 5,000 characters in your comment. So you can comment on a couple of different areas. If you need more space, then you submit that comment, you go back to that page and open up the next one. Or you can drag and drop your Word or PDF file here. And you can see at the very bottom of that page that I copied. I didn't copy the whole page, but you can see where it says upload files or drop files here. And that's where you do the drag and drop. So this is very simple, very easy, very beneficial for the industry, and something to consider. If it's beneficial for the industry, it's most likely going to be beneficial for your agency. Advocate for yourself, your agency, the industry, and make a difference in your future. Now, CMS has made a change to this page where we do this, and you can see that they have this beta site that they set up. And it's saying that on Tuesdays and Thursdays, they're going to be sending people to this new beta site. Okay, so you start here and it looks the same, but when you click on the Comment Now button, it's going to look a little bit different. It's not a big deal so far, and you would click on the comment button as opposed to the Comment Now button. And then it takes you to this landing page. Still looks pretty good. It's easy enough to submit your comments here as well. Okay, you can see where it says comment over there to the right. You just go in there and you start commenting. If you want to do a drag and drop a little bit lower on the page, but we don't see it here, you have that option. The good news is, as you can see over on the right, you can still submit anonymously. When you go in on this new system, this new approach, you identify yourself as an individual, you're submitting your comment as an individual, as an organization, or anonymously. Okay, as an individual, they're going to want your email, your name, that kind of thing. As an organization, they're going to want that pertinent information. Okay, but if you do it anonymously, there's no name and no email required. Okay, I've tried it, it works. I've done it on both pages so far this year. As of 10/18 on 8/17, there were 32 comments submitted. So that's not many considering how big an industry that we are. And you can see over in the bottom right, it's saying 32 comments received. Caveat, okay, this is a warning that I want to point out because the industry wants to be treated fair. They want to be treated on par with hospitals, SNFs, outpatient rehab facilities, etc. If we want to be treated on par with those agencies, we have to be similar to like those agencies. So part of it is they get a lot more participation in the rulemaking process. And if the home health industry doesn't significantly work to get what it wants, okay, how can it ever expect to get what it wants? In some ways, the home health industry is the biggest obstacle the home health industry faces to fair treatment. Now, I did do an update on this page today because I looked to see how many comments there were earlier this morning, and the comments jumped up to 56. Okay, it's still a far cry from where we need to be. And remember, this Monday is the deadline. Okay, now I've spent some time on the rulemaking process because it's far more important than what any associations and most agencies seem to realize. Nobody's really discussed the importance of the rulemaking process. Here we have an opportunity to impact our own future. Now you can do nothing and live with the outcome, just don't complain. It's like not voting in any election and then complaining about what happens in that election. You can make an effort and advocate for our industry and try to improve our industry's future. And by the way, I will point out several areas worthy of comment throughout today's presentation. My recommendation, though, avoid cut and paste. Just reword the comment enough to make the comment your own. It doesn't have to be a significant change, just reword it enough so it's not an obvious copy and paste. Now this year, the proposed rule is a pretty passive rule by CMS standards, considering the recent past. CMS is projecting an increase of $540 million in payments to home health. That's an increase of 2.6% for next year. So, question, rhetorical obviously, but question. Can all home health agencies expect to receive a 2.6% increase in their payments for calendar year 2021? No, they cannot. Some will see an increase in the 2.6% range, but most will not. Some will actually realize a greater increase in their payments, while others will realize an increase, but one that's much less than the 2.6%. And some will actually see their PPS payment rates decrease in 2021. Now, many things cause this discrepancy at the agency level. This year, the biggest impact has to do with the changes occurring with the wage indices for home health, which we'll be discussing shortly. This is why it's risky to assume that your agency should expect a change in the PPS payment rates as identified by CMS in either the proposed or final rule, and why I have always recommended that agencies have an analysis done on what this impact is projected to be for the upcoming year on their agency's Medicare revenues. And if you're one of the few agencies in the industry that actually does a budget, because most do not, you want to know what that change in revenue is going to be for budgeting purposes. A little work up front can save significant headaches later on. So for 2021, CMS is proposing no changes. We want to talk about the changes, but I want to point out areas where there's no changes, that there usually are, okay? The LUPA thresholds. So if a HIPS code had a LUPA threshold of 2 in 2020, it's going to have the same LUPA threshold of 2 in 2021, and so on for all 432 HIPS codes. The LUPA add-on dollar amounts are going to remain the same. The various aspects of the outlier provision and the 432 PDGM case mix weights. Recently, CMS has been updating and changing the current case mix weights on an annual basis, but not this year. So this is something out of the ordinary. However, holding the other three fixed is not so out of the ordinary, because they generally will change those periodically, but you're looking at generally 3 to 5, 6 years in between those changes. So following are the changes we're going to go over today. The wage index changes, the PPS payment update, the rule add-on payments, outliers. Now, even though I said there's no changes to outliers, I bring it up in a presentation like this because the vast majority of the industry does not understand the outlier provision well enough to make a take an educated position on whether or not it is worthwhile for your agency or your business, the industry. So I want to point out some nuances that most people do not understand. Talk about the RAP submissions for 2021 and the use of technology under the Medicare home health benefit. So the wage index. CMS is proposing to implement what they call the micropolitan statistical area subcategory of the CBSA that has been developed by the OMB. OMB is the Office of Management and Budget. OMB defines a micropolitan statistical area as a CBSA associated with at least one urban cluster that has a population of at least 10,000, but less than 50,000. CMS believes the best course of action is to treat these micropolitan statistical areas as rural. So those counties should be considered rural and include them in the calculation of each state's Home Health Rural Wage Index. CMS continues, thus, Home Health PPS statewide rural wage index is determined using IPPS hospital inpatient hospital data from hospitals located in non-metropolitan statistical areas. The result of which will be, and these are the changes, some urban counties will become rural. 34 counties would change to a rural status if this proposal is finalized. And you can see a list of those counties on table 3 of the proposed rule. Some rural counties becoming urban, meaning that they're moving from a rural status to an urban status. 47 counties would change to an urban status if this proposal is finalized. We can see those counties in table 4. Some urban counties would be in a CBSA that either changes its CBSA name or the CBSA number. 31 counties are in there, and we could see that those counties identified in table 5. And 19 counties would change to a different CBSA, meaning they're going from one urban setting to a different urban setting, but both are urban settings. And that those counties are going to be listed on table 6. So what's the big deal that nobody is talking about? What I mean here is I've talked to people all across the country about these things when the proposed rules come out, and nobody's really talking about this. And I think that's a mistake because every one of these changes will cause a change in the wage index for the counties affected, impacting the associated revenue for all services provided in those counties. Some it will benefit in that they will likely see an increase greater than what CMS projected, the 2.6%. Others, it will hurt. They're going to see changes less than CMS's projections. Their increase is going to be less than 2.6. They may even have reductions in their payments, with some being really hurt, okay? In that they will see some bigger reductions in their payment rates. And that's why CMS proposed putting a cap of 5% on the amount a county's wage index could decrease from 2020 to 2021, assuming the county was impacted by one of these moves. See the following. So following is a summary of the changes for 2 CBSAs from 2021. So we're going to look at what's happening between these 2 different CBSAs, and we're going to look to see what increased, what decreased, and what stayed the same. The first 2 columns that I don't have identified, that's identifying what's the change in the comorbidity values and what's the change in the LUPA thresholds. None of those changed, okay? Then we look over at the 3rd column under CBSA 1 and we see payment rates. Well, there are 432 payment rates in every CBSA, every service area. And all 432 payment rates in this service area increased. And not only did they increase from 2020, every single one of them is increasing by 16.4%. So that agency is going to have a pleasant surprise if they go in thinking they're only supposed to get a 2.6% bump. Conversely, we look over at CBSA 2, the comorbidities and LUPA thresholds, of course, stay the same, but all 432 payment rates for this agency decrease. And every single one of them decreases 5.5%. And although a 5.5% cut in revenues is not catastrophic in and of itself, it's difficult to be sure, but it's not catastrophic. It's a whole lot worse when you're expecting a 2.6% increase, because that's an 8.1% swing. So which CBSA would you rather be in? Well, of course, CBSA 1 is going to have a much easier time in 2021. Another issue germane to the wage index for home health is that home health does not have its own wage index. Never has. Hospitals do, SNFs do, hospice do, etc. But there's no home health specific wage index. Does that seem right to you? CMS uses inpatient hospital wage data in developing a wage index to be applied to home health payments, basically making us congruent with hospitals. So if you believe that the cost of labor for like-kind staff, nurses, therapists, etc., is basically the same for hospitals and home health agencies in your market, then this should be okay for you. But if you believe that there's a difference in the cost of labor and in the ability to attract and retain quality staff between hospitals and home health, and you think it's a little bit harder on in the home health sector, then you cannot think this is fair to home health. If you think like this would be a good topic to comment on. Maybe submit a comment that is something like this. And here's the first tentative comment. Why does home health not have its own wage index? CMS has developed a wage index for hospitals, SNFs, hospice, etc. It's high time that CMS create a home health specific wage index. So if you agree with this sentiment, then this would be something that you could type in, you could submit in the comments section. I would, again, just reiterate that I would request that you reword it to make it your own. So it's not an obvious copy and paste. Next, we're going to talk about the payment update. CMS has proposed a net market basket update of 2.7% for all agencies submitting the required quality data. Now, the market basket update of 2.7% is different than the increase in home health spending, which is 2.6%. Okay, this is not a typo. This is what it's supposed to be. Okay, so market basket update for those agencies submitting required quality data for 2021 is a 2.7% increase. The proposed update for those agencies not submitting the required quality data, that's OASIS, HCAHPS, etc., is only 0.7%. So they take the 2.7% previously noted and reduce it by 2 percentage points. Now, the national standard 30-day payment rate for 2021 is projected to be $1911.87. Currently, it's $1864.03. The 30-day payment period for those not submitting the required quality data is only going to be $1874.64. Following are the LUPA rates as proposed to 2021 for agencies. On the left-hand side, it's going to be the agency submitting the required quality data. On the right-hand side, it's going to be the agencies not submitting the required quality data. We can find this information in the proposed rule in tables 9 and 10. Now, I've noted several times that CMS is projecting that home health spending for 2021 will increase 2.6%. And I've also noted that it was unwise for an agency to assume that the Medicare payment rates for their agency would increase along that same CMS projected rate. Now think about this. When you hear anyone talk about the proposed rule, ever, I mean anybody that you've listened to this year, anybody that you've ever heard talk about it in the past, have you ever heard them say anything besides what CMS projects the change in home health spending to be? And therefore, did you think that's what it would be for your agency? Well, I've been going around talking about this for 20 years, and I've never heard anyone from any associations, from any agencies, whatever, say anything different than what CMS identifies as the change in home health spending. Okay, that's all they've ever identified, as though that's what everyone should expect for their agencies. Okay, and that's wrong. You have to look between the numbers and words to see what the impact really is. You have to have read and understood the rule. And believe me, everybody that does these kind of presentations doesn't read the rule. Okay, it's like trying to, somebody trying to tell you what's going on with your business, and all they look at is your total revenues, your total expenses, and your net income loss. Well, you have to look at the detail to be able to tell how your agency is doing both operationally and financially. That's just a 30,000-foot perspective. As they say, the devil is in the details. Okay, most just don't make the effort to attain that level of understanding. So just be careful who you listen to. And there's generally a difference between what the change in home health spending is proposed to be in any given year as compared to how it's going to impact any given agency that some year. Again, some agencies will do better, some will do worse, and some will do a lot worse. Okay, to emphasize, I want to bring back those CBSAs we were just looking at a moment ago that were over on slide 23. So CBSA 1 is going to see an increase of 16.4% for all 432 payment rates. Every single one of them is increasing by 16.4%, compared to CBSA 2, which is projected to realize a decrease of 5.5% for all 432 PPS payment rates, even though CMS projected that calendar year 2021 home health spending was going to increase by 2.6%. So Area 1 does 13.8 percentage points better than CMS's projection, and Area 2 does 8.1 percentage points worse. Therefore, do not take the CMS projection as a given for your agency. I haven't run scenarios for all 460 plus CBSA service areas, but I would expect that the impact to most service areas will fall somewhere in this range. A few service areas might exceed either extreme because of some of the more intricate changes CMS is proposing, specifically the changes previously with the wage indices, with counties moving from one service area to another. However, most agencies will not see an increase in 2.6% in their payment rates for 2021. In fact, there's only 2 service areas, CBSA service areas, out of the 460 plus that will actually see their revenues increase 2.6%. So how do you identify what the impact of Medicare revenues will be for your agency in 2021? Well, this is an easier year than most for doing this kind of comparison, as the only things changing are the market basket update and the wage indices. Okay, but regarding the wage indices, again, remember there's some complications in this area because of those counties changing service areas. Unlike every other year under PPS, where it's a complicated procedure, you can easily calculate the change for 2021 by calculating the 30-day payment rates for 2021 and comparing to 2020. Now, I've been doing this for years, since year 2 of PPS, going back to 2001, and I've done it every year ever since. First 7-8 years I did it, I was working for an agency and I did it for all our organizations. Since 2008, I'm a consultant, I'm doing it for clients. And I've always been confounded why this isn't an industry standard practice. Okay, this to me is a financial operational fundamental to home health, to our industry. This is one of those financial fundamentals that's greatly lacking in the home health industry, and unfortunately there's a great many of them, including budgeting, including doing monthly financial operational analyses, and the list goes on and on. Now, there's more to this analysis as well. I'm not giving away the ranch, but I'm not looking to teach other consultants, etc., what they should have been doing for the last 20 years. Next is the rural add-on payments, okay? And this rate is also changing for 2021, but it's changing following what was proposed and finalized back in 2018. So we see the following. This is the table for how the rural add-on has been changing for 2019, 2021, and projected to change for 2022. Now we see over in the categories, we have 3 different categories, and these are applicable to rural counties. Okay, we have high utilization rural counties, and these are counties that are still considered rural, excuse me, but they have a denser population base. Underneath that, we have low population density, and these are rural counties that have very low populations. Okay, and then we have all other, and that falls in between those 2. We can see in 2021, high utilization counties are not going to get a rural add-on for 2021. Low population density counties, those that have the fewest people per square mile, are going to see a 2% increase, 2% rural add-on for 2021, and that's 1 percentage point less than what it currently is. And then all others, the counties in between those 2, are going to see a 1% rural add-on for 2021. And I would think that the counties that switched from urban to rural that we saw earlier in the wage indices talk would be considered likely to be considered high utilization counties, meaning that they will receive no add-on payment in 2021. And calendar year 2022 is the last year of the rural add-on. This is not a CMS doing, as the rural add-on only exists because of congressional legislation. Therefore, over the next year, all agencies that provide services in any rural counties should write their members of Congress, urging them to extend the rural add-on payment for home health or potentially risk losing coverage for seniors living in those areas. Now, this per se isn't a comment that's going to be submitted via the rulemaking process, as we were looking at earlier. This is a comment that you would include in a letter to your the senators, the 2 senators for your state, and whatever members of the House are in the coverage area that your agency services. Next, I want to talk about outliers. And although I did identify there's no changes proposed for the outlier provision, it's the lack of industry-wide understanding of this provision that has me bringing it up here. So this is going to be a little complex, but I really would like you to pay attention to this because it could be a very big eye-opener. First off, for full disclosure, I'm letting you know right now, I am against the outlier provision and wish it would be eliminated. And generally, whenever I've sent in comments for the last 15 years, that's been one of them. Okay, more on that in a little bit. But I want to see how you feel about it once you have a better understanding of how this provision impacts your agency. That being said, let me identify the particulars of this provision. And again, these data points I'm going to be talking about initially are things that are not changing. They're what they have been. Now, the fixed dollar loss is remaining at 0.63 or 63%. This is the theoretical amount of loss you must incur before loss sharing kicks in. Now, remember theoretical and fixed dollar loss. Okay, we're going to come back to that momentarily. The loss sharing ratio is remaining at 0.8 or 80%. This is the portion of the loss in excess of the FDL that Medicare will reimburse. In other words, this is your outlier payment. CMS is going to continue to use the per unit approach. Historically, for the first 16 years, they used the per visit approach. The per unit approach became effective in 2017. Now, the calculation of episode costs is based on imputed costs. You know what imputed costs means, okay? Remember the theoretical I asked you to remember when we were talking about the fixed dollar loss? Well, the fixed dollar loss is calculated based on the imputed cost. The cost for the episode in this calculation is not based on your actual costs. It is based on the visits in the LUPA per visit rates. Meaning, if your actual costs per visit by discipline are greater than your LUPA rates, which is the norm for almost the entire home health industry, your actual loss, even after they pay you outlier payments, will be greater than the 63% FDL. And I have actually seen agencies target outliers thinking that they were profitable. Those agencies didn't last long. I tried to talk them out of it, but they didn't last long. And the cost of chargeable medical supplies are ignored from the calculation. The outlier cap for an agency remains at 10%, meaning outlier payments cannot exceed 10% of your total Medicare payments, inclusive of the outlier payments, and any outlier losses in excess of that 10% are lost. You're not going to get paid for it. The amount withheld from total home health spending to fund the outlier provision each year since 2011 has been 5%. This means that the outlier provision did not exist. Every PPS payment that you receive would be 5% higher but you would not receive any outlier payments during the course of the year. And I'm going to bring this up a few times because this is a pretty important issue. This is a vestige of the PPACA, the Patient Protection and Affordable Care. Okay, this was legislated in there. And the total amount of outlier payments to the industry for the year is capped at 2.5%. This too is something from the Affordable Care Act. So let me ask you, did you catch that legislative discrepancy? 5% withhold versus 2.5% cap and outlier payments. Okay, so they have this bucket that they sit over on the side that's 100% of home health spending. But before they do any kind of calculations, they skim 5%. They take the top 5% off and they put it in a separate bucket. And that's what they use to fund the outlier provisions. Okay, but only 2.5% is targeted for outlier payments. And it's this discrepancy that causes me to dislike the outlier provision. You know, the 5% withheld, yet there's a 2% cap on outlier payments, meaning 50% of what is taken out of home health spending to fund the outlier provision vanishes, disappears. It's never returned to home health. Maybe they use that money to buy that proverbial $500 hammer and $1,000 toilet seat, but it doesn't come back to home health. So, interesting point is, what is that in dollar amounts? Well, let's estimate that the average home health spending, annual spending, is $18 billion. And oh, by the way, that's a realistic value to go with. Okay, we get the following. The amount withheld, the 5% withheld, is $900 million. $900 million. Remember what they were increasing our spending this year? $540 million. Okay, so in the 2.5% cap in outlier payments, what they're targeting to pay in outlier payments for the year is half of what's withheld, $450 million. So the difference, the discrepancy, is $450 million. And that's the ballpark number that's been extracted from home health spending every year since 2011. And this year, being 2020, I mean the current year, not this proposed rule, 2020 makes 10 years that they've been doing that. About $4.5 billion. So what do you think about that aspect of the outlier provision now? Okay, are you still a fan, if you were a fan, or does it make you a little bit more adversarial towards that? Additionally, I would recommend everyone go back and take a look at their prior cost reports as well to see how they fared. How much did you receive in outlier payments versus how much was withheld from your agency to fund the provision? My expectation is that the vast majority of agencies throughout the industry have had their Medicare cash flows reduced because of this outlier provision, even though they got outlier payments. Here's another reason that most do not correctly understand the outlier provision. Okay, what most seem to understand are the outlier payments that they receive during the course of the year. These are tangible dollar amounts, and these amounts can be seen by everyone, and they provide some level of comfort that this so-called safety net is working. So they provide some sense of security. But is it a false sense of security? The aspect of the outlier provision that most don't really understand is the impact the funding mechanism for the outlier payments has on their Medicare revenues. And that is because nobody sees its impact on their cash flows, because it's done before Medicare payments are made. As previously noted, the bucket from which outlier payments come from is funded by reducing every episodic payment that an agency receives by 5%. So if the outlier payments provision did not exist, you would receive 5% more for every episodic payment, but you would no longer receive any outlier payments. Most are afraid of this loss of outlier payments, but if they actually compared what they lose in cash flow because of the funding mechanism to what they actually receive in outlier payments, they would likely see that the outlier provision is actually reducing their overall Medicare cash flow while providing a false sense of security through at least some outlier payments. In other words, they would have been better off receiving the increased payment rate for all episodic payments while also no longer receiving any outlier payments. Have you ever taken a look at this for your agency? You should, and you really should look at this over the last 10, even 20 years, the entirety of PPS, to get a real feel for what that impact has been. You may have had a year or 3 that you actually benefited from this provision, but chances are great that over the life of the outlier provision, it has been detrimental to your overall cash flows. So let's take a look at this, okay? This is information I've extracted from 2 cost reports, same agency, 2 different years, okay? We have year 1 and year 2. So in year 1, they received outlier payments of over $71,000. In year 2, they received over $127,000 in outlier payments. So that's a lot of outlier payments. So with what agencies generally know, do they want to give this up? In a heartbeat, the answer is no. The real question is, should they? Should they want to give this up? And the only way to do that is to compare what you received with what they took away to fund the outlier provision. So when we do that comparison, we see that in year 1, the reduction to fund the outlier provision was almost $174,000. So they actually lost out on over $102,000 in cash flow, Medicare revenue. That's monies that go straight to your bottom line because there's no associated expense with it. It's expenses you already incurred. In year 2, they lost almost $94,000 because of the outlier provision. More was withheld to fund the outlier provision than what they received in outlier payments. So you might want to do or have done for you something similar to this so you can identify how this provision has impacted your agency. And if you think that maybe the outlier provision is more detriment to your agency and the industry, then maybe consider submitting a comment to CMS that's something like, as the provision for outlier payments is optional, we respectfully request that you eliminate the outlier provision as a factor in home health and add back the 5% of funds currently withheld to fund outliers. Again, just change the wording a little bit. Doesn't have to be significant, but change it a little bit just to make it your own. Next, I want to talk about RAP submissions, what's happening with those in 2020. And there are some big changes you really need to be aware of in this area. Okay, first, the RAP payment goes away. And the RAP will change its name to a no-pay RAP. Agencies will submit no-pay RAPs for all 30-day pay periods beginning on after January 1, 2021, and will submit no-pay NOAs for all 30-day pay periods beginning on after January 1, 2022. An NOA just stands for a notice of admission. It's similar to the hospice NOE notice of election. Okay, so the terminology is going to change, but the concepts are going to stay the same from 2021 to 2022. All no-pay RAPs and no-pay NOAs must be submitted within 5 calendar days from the start of care, or financial penalties will apply. And when I say within 5 calendar days from the start of care, the math would actually look like start of care date plus 4. So it's a 5-day range, days 1 through 5. If you submit on day 6, there will be a 20% penalty. That first day late, you're already losing 20% of what the episodic payment is supposed to be. Okay, and the calculation you see over to the right, 6/30ths. The 6, the numerator, is the day number of the 30-day pay period in which you are submitting the no-pay RAP. Okay, so we're submitting this on the 6th day, so 6 becomes the numerator. And the denominator is always 30 because there's 30 days in the pay period. So if you submit a RAP on day 10, there would be a 33.33% penalty. And if you submit a no-pay wrap on after day 30, a 100% penalty would apply. You would not receive any payment whatsoever, regardless of what you did for that pay period. The takeaway here is submit your no-pay wraps timely, get them out in days 1 through 5. Now, to minimize the documentation burden going forward for the industry, okay, since there is no payment associated with the no-pay wraps, CMS has also lessened the documentation requirements. See the following. This is extracted out of the proposed rule. We're looking at the highlighted parts, and they're stating that we are finalizing a policy that submission of no-pay wraps can be made when the following criteria have been met. And the criteria is much less than what it is right now and what it historically has been. And there's 2 criteria, and they're both right here. The first one is the appropriate physician's written or verbal order that sets out the services required for the initial visit, has been received and documented as required. And criteria 2, the initial visit within the 60-day certification period must have been made and the individual admitted to home health care. Okay, now some people might get a little taken back when we're talking about 30-day pay periods, but we're talking about 60-day certification period. Remember, it's the OASIS that drives everything. Okay, in the OASIS, the certification period of the OASIS is over a 60-day period, and there are 2 30-day payment periods within that one 60-day certification period. Additionally, CMS states they will allow the advanced submission of certain wraps in 2021, such that in instances where a plan of care dictates that multiple 30-day periods of care will be required to effectively treat the beneficiary, we will allow the agency to submit both the wrap for the first 30-day period of care and the wrap for the second 30-day period of care, covering the entire 60-day certification period at the same time to help further reduce provider administrative burden. So CMS is trying to make some things easier for us. Also consider the timeliness of submitting your final claims. This impacts your cash flow, so it is vital to an agency's health, and it's going to become more important in 2021. The longer this takes, the slower your cash conversion process is. You want to work with your policies and procedures along with your staff or whatever groups you have that work on the revenue cycle to minimize the number of days after the end of episode that you can bill. Remember, cash is king. And the elimination of the partial payment associated with the wrap that we currently get in 2020, that's going to disappear in 2021, is going to emphasize the importance of billing timely. And you also want to have a conscious, diligent effort to reduce your days of accounts receivable, also known as days of sale outstanding, to the 35 to 40 range, soon even lower, maybe in the 30-35 day range. Time will tell, okay? Because historically, when we had a 60-day episodic period, okay, and the payment period was that same 60 days, our days of accounts receivable was in the 40 to 45 range. Now, the payment period is dropping from 60 to 30. So there has to be a drop in the days of AR. I don't think cutting that number in half is reasonable, but maybe eventually it would be, but initially, no. But it has to drop down into the 30-35 range fairly soon in 2021. And our last area of discussion is the section CMS identified as the use of technology under the Medicare home health benefit. And this is telehealth, remote patient monitoring, which in this pandemic has really stood out for all aspects of healthcare, not just home health. So note the following as excerpted from the proposed rule. The Secretary shall consider ways to encourage the use of telecommunication systems, including for remote patient monitoring, et cetera, very positive sounding position by CMS. And again, this is extracted from our proposed rule. So this is, it's general comment, but it's germane to us in home health. So this is a very positive sounding position by CMS. Further, they go on to say that the plan of care must include any provision of remote patient monitoring or other services furnished via a telecommunication system and note that and is capital, okay, describe how the use of such technology is tied to the patient-specific needs as identified in the comprehensive assessment, the OASIS, and will help achieve the goals outlined in the plan of care. Okay, again, it's a positive sound, but agencies, home health agencies, have actually been able to use telehealth, I mean, for over 20 years. The old agency I was at, they sold in 2008, but from 1997 through early 2008, we were using telehealth for most of that time. And where you see that above, where you have the where it says and describe the use of such technology in the plan of care, I think that actually makes it a little bit more restrictive, but at least they're making it obvious that we can use it. Then there's these additional 2 points where it's section 40943 and section 40946. In 40943, they're saying that we are proposing to allow agencies to continue to report the cost of telehealth, telemedicine as an allowable administrative cost in line 5 of the home health agency cost reports. Historically, when we were using it way back when, telehealth costs, even though it was unquestionably benefiting the Medicare beneficiary, was treated as a non-allowable cost, meaning that it was removed from costs before the cost report calculated what our Medicare cost per visit by discipline was. We got a problem with the cost reports too, but that's a topic for another day. And then in 409.46, they said they proposed to amend to include not only remote patient monitoring, but other communications or monitoring services consistent with the plan of care of the individual. So I want to point out a little bit more about these 2 topics that they want. This one is 42 CFR 409.43. The big change here is highlighted in yellow, and I'll leave that to you to read. I just want you to know that when you see CFR, that's the Code of Federal Regulations. That is the federal law of the land. All federal laws are in the CFR, the Code of Federal Regulations. The 42, the prefix, identifies that these laws are germane to healthcare services. And then the 409.43 and whatnot, these are just subsections within the healthcare section of the Code of Federal Regulations. So this one has to do with our ability to use telehealth, remote patient monitoring, and this is just the changing the verbiage. Originally, it was only for the public health emergency, but CMS is proposing to make this permanent. And 409.46, again, this is 42 CFR 409.46. They go on to describe a little bit more about remote patient monitoring and what those activities are that would be considered allowable and consistent as allowable administrative costs. So everything is sounding good so far regarding potential opportunities for utilizing telehealth remote patient monitoring services in home health going forward. And our brethren, meaning hospitals, SNFs, outpatient therapy facilities, etc., have all been granted with the ability to treat certain, if not most, telehealth remote patient monitoring interactions with the Medicare beneficiary as allowable chargeable visits as part of their operations. Hooray, that sounds great. Okay, and then we read the following in the proposed rule. There's 2 sections. I'm just going to talk on the first. The second is just expounding on the first. And they state that these services cannot substitute for a home health visit as ordered as part of the plan of care and cannot be considered a home visit ordered for the purpose of eligibility or payment. So it's not an allowable chargeable visit. It is not a visit that counts against our LUPA thresholds. It's just a benefit that the patient gets. And all of a sudden, the proposed changes are a whole lot less positive for the home health industry, at least in regards to telehealth. Although the allowability to treat telehealth costs as allowable administrative costs is a positive, this is not due to the pandemic, which most of the reading makes it sound like, as it has been in the works since 2018. And it would be much more beneficial if these costs could be attributed to the cost center disciplines utilizing telehealth, as opposed to treating as an administrative cost, that all get allocated to all cost centers, including non-allowable cost centers, and including those cost centers that make no use whatsoever of telehealth. So there's a potential comment here. However, CMS is not allowing home health to treat it as an allowable chargeable visit. But can it be a skilled service? Of course it can. Whereas hospitals, SNFs, outpatient rehab facilities, they get to treat it as an allowable chargeable patient visit. So does this seem fair, reasonable, and or consistent to you? It does not to me, and that's what makes this an issue worthy of comment. Following are a couple of potential comments for this area. The primary comment would be, we request that home health be able to treat the telehealth remote patient monitoring visits as allowable chargeable visits as part of the Medicare home health benefit. That's the big one that we would want, because if we got that, then it would be a chargeable visit. It would be something that would count against our LUPA thresholds, etc. Okay. Secondary is we request that home health be able to attribute the cost of providing telehealth remote patient monitoring to the disciplines involved in providing that service, whether it's nursing or therapy, as opposed to treating it as an admin cost, because that becomes problematic because of the allocation process and the issues with the cost report. And that concludes our detailed look at the 2021 proposed rule. So we've discussed the following areas: that the wage index changes, the PPS payment update, the rule add-on payments, outliers, the RAP submission changes for 2021, and the use of technology on the Medicare home health benefit. And we started with a discussion on the importance of increased industry participation in the rulemaking process, that we need to increase the couple of hundred comments generally submitted to several thousand comments submitted by the industry each and every year, because both the quantity and the quality of comments submitted makes a difference. And we also talked about numerous issues worthy of comment from this year's proposed rule, including telehealth remote patient monitoring, and there's two potential comments here that I identified: changes in the service area of over 100 counties, creating a home health specific wage index, the outlier provision, and anything else identified in this proposed rule. So I hope that you were okay with the way that my presentation was, because a lot of it was read, but I was the one that put this together, and I wanted you to have that level, that depth of information that you can carry forward with you to help share with your staff and your organization. And with that, I want to thank you for your time, and I'll pass it back to Megan, because it looks like we now have some time for Q&A. Megan?
We do indeed. Thank you so much. One quick question that we have, John, that I can answer is, will we receive a recording of this webinar? Yes, you will. So I would estimate sometime next week, maybe the week after, depending on how quickly we can get this edited. We will be sending an email out to all of the registrants with the recording link and a link to the handout. Just a reminder, the handout is available on the panel that says handouts. You can click that to download or open that up. John, we do have some questions. First question is about submitting comments. When we submit a comment or comments, should we submit as an individual, as an organization, or anonymously?
That's an individual choice. It doesn't really matter. To a large degree. The important thing is that the comment is submitting. If you're submitting a non-confrontational type of comment, it's certainly worthwhile submitting it under your organization's name, because that's not something that's going to potentially get you targeted. But it doesn't really matter. It's the comment that's important.
Excellent. Another question about submitting comments. If we find that the outlier provision has actually been beneficial for us, do we go ahead and still submit a comment to have it eliminated from PPS?
No, of course not. You leave that up to the people that are having a problem with the outlier provision. One of the ways to look at your decision tree, the decision matrix of whether do I want to comment on this topic or not, is look at it from a selfish perspective in regards to your agency. If the change you want to have happen is going to benefit your agency, great topic to comment on. If it's not going to benefit your agency, then you leave the commenting to everybody else and you just let the sleeping dog lie.
All right, looks like we've got yet another question about submitting comments. How should I look at the issues in the proposed rule to identify whether or not I should submit a comment?
Well, that's a that could take a while to address. To try and put it succinctly, you really need to read the proposed rule to be able to identify those comments outside of what I've identified. Okay, because I know that, yeah, I would say that less than 1% of all the people that work in this industry actually read the proposed or final rule on a given annual basis. So you can do that, be the way to do that. But the other way to do that is by attending presentations such as this, that give a bigger picture perspective of certain areas. And if certain areas seem pertinent to you and your agency, then you can go back in and read those sections of the proposed rule if you didn't get enough information in the presentation to make a determination at that point in time. And oh, by the way, anybody that wants a copy of a bookmark copy of the proposed rule, you can go to my website and just read the blog on the 2021 proposed rule, and there's a link that you can download.
Excellent. Question about wage index changes. If our agency is based in one of those counties that changed, does this change impact all the revenue that our agency earns?
The answer is yes, if all the revenue, all the Medicare revenue that the agency earns is earned in that county. If you work in multiple counties, okay, the portion of your revenue that's earned for the services provided in that county will be impacted, but the other surrounding counties would not. It's specific to that county, the counties. They're all county specific.
Okay, and then how can we calculate what the change in Medicare revenue will be for our agency for 2021? Can you calculate it for us?
Well, I could certainly calculate it for you. I mean, that's part of what I do. But you have to understand how the rates are calculated. And then, short of, going through that description, it's tough. It's tough to really identify how you would go about doing that calculation. You already know what your payment rates are for your EMR is already going to know what your payment rates are for 2020. So then you just have to calculate out what they're going to be for 2021. But sure, I could do that. I mean, I've been doing that for 20 years, so.
Great. I've got another question about commenting, John. Is there any ability to comment on issues related to PDGM if that was not addressed in the proposed rule?
Sure, you always have the opportunity to submit comments. I mean, because this is a PDGM rule. This is the second year that we are under PDGM. So you can submit comments regarding PDGM. And to what extent your comment is, like if you're saying, hey, we think you should get rid of PDGM, I think the likelihood of that happening is lottery-like. But you can comment on anything when they open up what they've done. I mean, one of the comments that I'm saying that we want to be allowed to have the visits with the telehealth is something that flies in the face of what they've already identified in the proposed rule. But I think that we should have thousands of comments out there that say we should get this because everybody else is getting it too. Why are you treating us differently?
Great answer. Question about payment update. You mentioned there's a lack of financial fundamentals in home health. Well, what are they exactly?
Well, I mean, I alluded to a few of them earlier. financial fundamentals, business fundamentals, these are things that are germane, that are common occurrences in business, not just home health, in business. Doing a budget, common occurrence. Everybody, almost all businesses and all industries do a budget. In home health, less than half of the industry does a budget, and 80% of those that do a budget that's basically worthless for measuring your agency during the budgeted year. Doing what I call a monthly financial operational analysis. Every month when you close your books, you should be analyzing the results. Okay? Don't live on revenue, total expenses, and bottom line. That's not where the information to manage your business is. The information is in the detail. Every admit that you get, you should be doing a financial projection for every admit that you get. When Ford, they're building a vehicle, they have a budget built for that vehicle of how much that vehicle is going to cost and how much their revenue they expect to get for that vehicle. These are just a few examples of the things that we could do that as an industry we do not.
Very good, John. Looks like we've got time for one last question, and this is going to be about telehealth. Do you think it's likely they will allow us in home health to treat telehealth visits as allowable, chargeable visits that suffice for the plan of care and count towards the LUPA threshold?
For calendar year 2021, I would say that's extremely unlikely. But I think the more comments that we have submitted this year towards that end increases the likelihood in future years, 2022, 2023, to where we can get telehealth visits to be treated as allowable, chargeable visits for us in home health. So everything we do isn't about the here and now. We also think about the future.
Well, very good. Well, John, I want to thank you for joining us today, and I want to thank everyone else. You've given us such great insight into the home health proposed rule. I hope that everyone takes the time to submit comments to CMS so we can really make an impact on our future. Once you leave today's webinar, you will see a pop-up survey. Please fill out this survey and give us your feedback. You can also let us know within that survey if you'd like to connect with John and any of the services that he provides, or if you'd like to learn more about HealthRev Partners RCM services. So on behalf of HealthRev Partners, thank you for joining us today, and we hope that you have a great rest of your day.